Greetings from Colorado. I'd like to thank the organizers of NEIMS for inviting me to give this presentation on an update of stenting in pseudotumor in IIH. These are my disclosures. This is my first patient I stented in 1999. She was 41. She'd had IIH for more than 20 years and was legally blind. So clearly she had a lot of damage to her optic nerves. She'd had multiple lumbar drainages, shunts, revisions, fenestrations. Then they discovered on MR that she had some dural sinus stenoses, and they sent her for a stent in case that might help. You can see that she had bilateral transverse sigmoid stenoses that we came to recognize and a gradient of 31. After stenting, the gradient dropped to 4, but her symptoms didn't improve that much. Headaches got better, vision got a little better, but didn't improve nearly as much as we had hoped. And that was undoubtedly due to the amount of optic nerve damage she'd already suffered. Well, about 3.5 years later, the vision got even worse and symptoms got worse. She had an opening pressure of 37 and she had another shunt revision. She moved out of state, and in another state 6 years later, she did have an angiogram for other reasons. The physician who did this sent me these pictures, and you can see that the stent is patent, but that she also has this stent adjacent stenosis, which we did not know about at the time. And that's why the treatment had not done better than it did. But this was not an outstanding result. I did not report it. The first report of a successful stenting was in 2002 by this group from England. 12 years later, they reported 12 cases, or I'm sorry, the next year, they reported 12 cases. And then that is when stenting started being done. And it's really taken off. Here recently was a report of a single center in France who reported 200 patients that they'd stented. Now, this is a review of multi-center review published in 2019 of 474 patients from 18 centers in the US, Europe, and Australia. 88% were female, 12% male. Mean BMI was 35. And universally, what was seen is that papilledema is cured by stenting, and as is pulsatile tinnitus. Headaches, not quite so much, about 80%. Now, in this population, that's improved and cured, and most of these are improved. Not that many are actually cured. There is a recurrence rate of about 12% recurrent stenosis, mostly treated with restenting. This was a review that came out this year of the invasive treatments, all of them, of IIH, encompassing 109 studies, 2,300 patients, large number of patients for fenestration, shunts, and stenting, fewer patients for bariatric surgery. Bariatric surgery is not a good treatment if patients have severe papilledema and deteriorating vision. So mostly we need to look at these three. Papilledema does respond well to any of these invasive treatments, perhaps a little less well with shunts. Headache does not respond quite as well, nor do visual symptoms. And again, the visual symptoms would depend on how much damage there was to the optic nerve before the treatment. The failure rate at 12 months is high for shunts, and the complication rate, severe complication rate for shunts is higher, and for bariatric surgery is higher than for fenestration or stents. And these are severe complications. Now, it's been known for some time that IIH is a manifestation of the final manifestation of multiple different disease conditions, and there are multiple different patient populations. The difference in patient populations was dramatically illustrated by this study that just came out from Jiantan a couple of weeks ago. And this is a single center experience. Presumably all of these are Chinese patients. And when you compare these with a previous study I mentioned, you can see there's a much higher proportion of males and a dramatic difference in BMI, 9 points here. So clearly these are different patient populations. and yet the response to stenting is the same. This is follow-up at 6 months, and papilledema, again, is very well controlled. Now, in this population, the Chinese population, headache was controlled completely in 90%, which is better than these other series here. On the other hand, there was a difference in recurrence. Now, most recurrences happen after 6 months, so this number may change. We also know that there are different kinds of narrowings, so different diseases associated with IIH, intrinsic and extrinsic, and then a combination. This is the extrinsic compression that happens at the TS-SS junction, and it's this typical scalloped indentation. These are intrinsic filling defects in the transverse and sigmoid sinuses. This is a combination where you have an extrinsic compression from the increased intracranial pressure, but there's also an intrinsic lesion, this sort of polypoid shaped thing, which is producing the pressure gradient in this dominant sinus. This is probably an arachnoid granulation. Now, universally, the reports indicate that stenting is equally effective for intrinsic and extrinsic stenosis. Now, the next point is that superior sagittal sinus pressure is critical. The cerebral spinal fluid pressure is highly correlated with superior sagittal sinus pressure, which means when you're measuring pressures, you need to measure it in the superior sagittal sinus. Also, you need to normalize the pressure in the superior sagittal sinus with stenting. If you have a dominant sinus, which side do you stent? And the answer is you stent the dominant sinus, because that's where the superior sagittal sinus drains. Here's a patient with a dominant sinus, and you can see the superior sagittal sinus empties into the dominant sinus. The straight sinus empties into the non-dominant sinus. And sometimes there's very little connection between the two, as was present here. For more than a decade, we've been stenting from the medial transverse sinus into the sigmoid, regardless of the type of stenosis. And I'll show you both the reason for that and something to watch out for from 2 technical errors that I made. Now, here's the reason why we started stenting that way. In this instance, you can see this is that patient with a polypoid type of intrinsic stenosis here. And I stented just the stenosis. And you can see at a 13-month follow-up here that the stalk-like area of that lesion is not covered by the stent. Now, at 62 months, she developed more symptoms, and the pressure gradient had gone up and was starting to get papilledema. She didn't have that much vision left, so we wanted to make sure papilledema didn't get worse. You can see what happened here, that lesion has popped out from underneath the stent and is once again producing venous obstruction. And that was fixed just by restenting it, and she had no papilledema 3 years later. Stenting, if you stent from the medial transverse sinus, you won't run into that problem. But do be careful of this. Now, this was variant anatomy, but I made a mistake here. Here you see bilateral stenoses, a gradient of 23. She has an anatomic variant with a high bifurcation of the superior sagittal sinus. I stented into the medial transverse, and I got a little too close to the curve. The gradient dropped to 10. I wish it were lower, but her symptoms did get better for a while. But by 10 months, she had recurrent symptoms. And what happened is there was a kink at the upper end of that stent. And there was now a recurrence of the gradient, and a gradient of 21.5 again across that side. And then the gradient was still there on the other side. So once again, she had bilateral outflow stenosis. So what I did was to stent the other side, staying well short of the curve on the other side, and reduce the pressure gradient to 3. And here she was 30 months later with a pressure gradient of 2, and she had no papilledema at 54 months afterwards. So don't make that mistake. Now there's this phenomenon that we came to learn called stent-adjacent stenosis, and that's development of a new narrowing in the normal sinus above the stent with a recurrent gradient and recurrent symptoms. In our experience, this happens in young females who have high BMIs and who have extrinsic stenosis. Here's one such example where I put in a short stent to cover just the stenosis, and 8 months later, she's developed a new stenosis in that previous normal sinus with a recurrence of the gradient. Complete stenting of the transverse sinus, as I did here, doesn't necessarily mean there won't be a further problem. And you can see there is a new gradient at 17 months after stenting, and the patient now has narrowing of the previously normal posterior superior sagittal sinus, as well as narrowing of the other sinus. That's led us to doing extended stenting into the superior sagittal sinus. This was our first patient. She was 23 and was losing vision, opening pressure of 55, referred for urgent stenting. After stenting, her pressure gradient was 3, and the symptoms were gone. But 15 months later, she came back with recurrent papilledema, bad headaches, and an opening pressure of 51. When we studied her, you can see she's got narrowing of the posterior superior sagittal sinus and a gradient of 33. She was very adamant that she did not want a shunt, and so we did another stent into the posterior superior sagittal sinus. And here she is 8.5 years later. Her gradient is 5, and she has no papilledema. Sometimes just the posterior superior sagittal sinus is not enough, and you can see this patient developed stenosis in the mid superior sagittal sinus above the first stent. So we put in another stent, and here is that patient with a normal gradient 26 months later, and she has no papilledema 96 months after we put in that second stent in the mid superior. On one occasion, we had to stent the entire superior sagittal sinus. This lady had had a failed nerve fenestration. She was losing vision and was referred for urgent stenting. My partner did 3 stents over 10 weeks. First, the transverse sinus to the sigmoid, then into the posterior superior, and then into the mid superior sagittal sinus, all without change in the papilledema or headache. And here she was 6 weeks after that, and you can see she still has a stenosis above the most recent stent. So we stented that. And for the first time, her papilledema resolved. Here she was 10 months later with a normal gradient, and she has no papilledema 58 months after that. Which led us to think about doing primary stenting in a few patients into the superior sagittal sinus. Now here's a young woman with a BMI of 54, American diets, and an opening pressure of 40. And her vision is doing very poorly, referred for urgent stenting. She has the extrinsic compression you would expect in a gradient of 21. And here, by this time, we knew that if we just did a transverse sinus stent only, she's going to fail. So from the beginning, I did a stent into the posterior superior sagittal sinus, which is normal, you can see. Well, here she was at 2 years with a normal gradient, and she had no visual disturbance, no papilledema, no headache, 58 months after stenting, even though her BMI had risen to 60. I'm going to report, these aren't reported yet, the experience of follow-up in these first 8 patients that we've done. Unfortunately, there is no other report of a series of superior sagittal sinus stents in the literature to date. I hope that changes. But of these patients who have longer-term follow-up, all of the stents have stayed patent. None of the patients has papilledema, and a follow-up from 3.5 out to 101 months, either the primary stenting patients or the patients who were stented for hemodynamic failure. So our conclusions are that with very limited experience, extended stenting seems to be a very favorable thing to do. If you get stenosis above the posterior sinus stent, restent the stenosis. Now, these are the modified Dandy-Friedman criteria for what constitutes how you make a diagnosis of IIH, and you're familiar with these. Notice that there's no consideration of etiology. And we do know that these are associated, particularly the papilledema patients, with venous congestion and venous stenoses. The stenoses do not have to be intracranial. This group from Xuanwu in 2018 reported on 45 patients, 15 of whom had stenoses in the internal jugular veins, and they had some degree of papilledema. By stenting the internal jugular vein stenoses, the patient's papilledema was alleviated. Now, the same group a year later did point out that when there is a dural sinus stenosis, an intracranial stenosis, those patients had the more severe and more common papilledema and visual damage. That internal jugular stenoses had less severe papilledema and were more characterized by abnormal collaterals in the neck. But this has opened up a whole new area of investigation, and this paper has just been published. Dr. Hui is the senior author on this, and he's going to be talking about this and these results very shortly. This is an exciting new area of looking at cerebral venous congestion as the basis not only for IIH, but hopefully and perhaps for many other neurologic situations as well. He will be talking about this in just a few minutes, and I'm very much looking forward to hearing from him. This is an exciting new area. So what do we know in 2021? We know that stenting works for any kind of stenosis. We know that we have to normalize the superior sagittal sinus pressure, that stenting addresses the venous outflow restrictions. The other treatments did not, shunting, nerve fenestration. Stenting is safer and more effective than either shunting or nerve sheath fenestration. Thanks very much. I appreciate your attention.